Hello, this is Marla Dalton, Executive Director and CEO of the National Foundation for Infectious Diseases, or NFID. Welcome to the first episode of Contagious Chronicles, a new series from NFID featuring insights from trusted experts on the latest developments in infectious disease prevention and treatment. With me today are two esteemed colleagues and NFID leaders, Medical Director Dr. Bob Hopkins and spokesperson Dr. Bill Schaffner, to talk about the new COVID-19 vaccine recommendations for older adults and other updates from the February 2024 meeting of the Advisory Committee on Immunization Practices, or ACIP. Thanks so much for joining me, Bob and Bill, and for helping to interpret the key takeaways from the recent ACIP meeting.
Good morning, Marla. Happy to be on with you and Bill.
Likewise. Good morning.
Good morning. So, Bob, perhaps the biggest news from the meeting is that the Centers for Disease Control and Prevention, or CDC, is now recommending that U.S. adults aged 65 and older receive an additional dose of updated COVID-19 vaccine this spring, right now. Less than half of older adults in the U.S. are currently up to date on COVID-19 vaccination, unfortunately. So what is the reason for the new recommendation? And frankly, why do these COVID-19 vaccine recommendations continue to change?
Well, before we talk about updates, I think it's really critical that we mention that most in our country, particularly in our children, most have not received the 2023-2024 COVID-19 vaccine. And everyone 6 months of age and older who has not yet received it should get the 2023-24 vaccine as soon as possible. This recommendation goes back to September of last year, and this leaves many vulnerable to this preventable infection. I think it's important for us to think about the fact that we are still in the midst of the learning phase about COVID-19. All of us in healthcare and in the communication spaces need to recognize that changes in recommendations are challenging for many people to understand and to accept. We need to maintain transparency with each other and with the public, not only what the changes are in our recommendations, but also why they're being changed. We're still learning from and about SARS-CoV-2, the virus that causes COVID-19. We continue to see thousands of hospitalizations with hundreds of deaths every week across the U.S. We continue to see new variants with different illness characteristics and the potential to escape immunity from prior infections and vaccination. The population at the greatest risk for hospitalization and death remains older adults, especially those who have chronic medical conditions and immune suppression. ACIP reviewed the data on how well the vaccine works in reducing that risk for infection and severe disease. We know that vaccination protection wanes over time, and they made the recommendation that we need to vaccinate with an additional dose our patients 65 and older at least 4 months after their last dose of vaccine to protect this older, vulnerable population.
You know, Bob, you're right on the money, and particularly so to remind everybody that such a low proportion of the population has yet to take advantage of this updated vaccine. But this new recommendation actually was stimulated in part by the very people who had been vaccinated. These are the people who are very committed to prevention, and they began to ask the following question. Look, I've been vaccinated, but we know that this vaccine's protection begins to wane a little bit after 4 or 5 months. And they anticipate being out and about with many people this summer, and they asked, shouldn't we get yet another dose of this vaccine to protect us through the summer before we get a new vaccine in the fall? And so I think this recommendation was in part a response from to these questions that came from people who wanted to really be focused on prevention and good for them. And I'm all for this new recommendation that if you've been vaccinated previously and 4 months have elapsed, it's now time to get another dose to protect yourself going to the summer, particularly those people who are high risk of getting serious disease. Sounds good to me.
Absolutely agree.
Yeah, likewise. So Bill, I know you love to pull out your crystal ball. I'll ask if you have any predictions on when we can expect to see the next new recommendation.
Yeah, actually, the crystal ball, I think, is pretty clear on this one because Dr. Mandy Cohen, the CDC director, has actually been pretty clear that we're now in track to update our COVID vaccine each fall the same way we update our influenza vaccine. And so it's anticipated that this fall, everybody will be asked to roll up both sleeves, get that flu vaccine and get the COVID vaccine. While we're thinking about this, let's all cross our fingers. The vaccine scientists are trying to work on a combined influenza and COVID vaccine so you could get protected just from one shot. We're not there yet, but let's all hope together. I prefer that myself, I must say.
Here's hoping. So Bob, the ACIP also reviewed safety and efficacy data for vaccines against flu, respiratory syncytial virus or RSV, and other diseases. So let's start with RSV here. There were some safety signals on the RSV vaccines and some questions about who really is at greatest risk for severe RSV disease. I'd love to know what your thoughts are on these issues.
Well, CDC and FDA had multiple robust vaccine safety systems for ongoing surveillance of vaccine safety across all vaccines. Presented at the meeting was some preliminary information that showed a few cases of Guillain-Barré syndrome per million doses of vaccine following both of the RSV vaccines. This was seen in the Vaccine Adverse Events Reporting System and also in a system called BEST that the FDA monitors. And it's important to recognize that these are preliminary data. Further studies which have the potential to provide us more conclusive answers about whether this Guillain-Barré is associated with the vaccine are planned in the near future. And on the question of risk, we got some really important data from the CDC system called RSVNet that showed that with increasing age, from 60 and up, your risk for severe RSV disease and hospitalization goes up. If you have chronic medical conditions, that risk goes up, particularly if you have 2 or more chronic medical conditions. So important for us to know this information and better drive our recommendations for RSV vaccination with our shared decision-making going forward.
So Bill, building on that a bit, I'm curious what you would say to a patient who has lab confirmed RSV this current season. Would you tell them to get vaccinated now, later, and what general guidance would you give them?
Well, RSV vaccine is becoming, as was discussed at the ACIP meeting, another one of those vaccines that we should think of getting this fall, in addition to flu and COVID. So I would suggest if you've had a documented RSV infection this past season, glad you're better, and be alert. Next fall, get your vaccine.
I like that. And I know that, in the US, we typically think of respiratory viruses being fall and winter concerns only. So, Bill, I'll ask you what advice you have for older adults about getting vaccinated against COVID-19 or RSV in the spring versus waiting until the fall.
Well, COVID's a bit different because COVID is active the year round. We have kind of 2 surges or increases of COVID. We do have a summer increase and then a larger one in the winter. So if you're a high-risk person, I would certainly recommend your COVID vaccine right now if you have never received it. And as we've just talked about, if you have received the vaccine and 4 months have elapsed, sure, get your booster because that's now currently recommended. Also, RSV, I would wait until the fall, and don't forget your flu vaccine.
Bob, anything you want to add to that?
Amen.
Perfect. Bob, I'm going to shift gears a little. I know there was a lot of discussion about the specific language of the recommendations in terms of may versus should for COVID vaccines, for example, and the whole idea of shared clinical decision-making for RSV vaccines. Can you explain the significance of the ACIP discussions and help us understand the so what here?
Certainly. Well, a should recommendation is really very easy. That's our traditional vaccine recommendation. Everyone in that particular population group being considered should get this vaccine. The benefits of the vaccine clearly outweigh risks for everybody in that age group. That's the type of recommendation we have for influenza vaccine for everybody 6 months of age and older. A may recommendation, otherwise known as a shared decision recommendation, it's a bit more nuanced. The vaccine benefits are not necessarily the same for everyone in the population for whom the recommendation applies. There should be a discussion between the patient and the healthcare provider about the potential benefits and risks for the vaccine in that particular person. Going back to RSV, as we talked about a moment ago, a healthy 60-year-old who's not spending much time around older adults or small children probably has a relatively low benefit for RSV vaccination. However, a 75-year-old who's got chronic kidney disease and COPD is at very high risk for hospitalization for RSV. And so the shared decision would be encouraging of them to get the vaccine. Hope that helps to answer those questions.
Absolutely, thanks.
So Bob,
Go on, Bill.
I do it very similarly. I would just add a little bit to that. With increasing age, as you said, the risk goes up. And if you add any chronic medical condition at any age, the risk of your getting severe disease goes up, which means that for me as a provider, my, if you will, recommendation becomes more firm as those risk factors increase. And I would hope that the receptivity of the patients also, once they get that information, increases also.
And it's also probably important that we mention here that while many people are getting these RSV vaccines in the pharmacy, it really emphasizes again that we've got to have good collaboration, good communication between all the different parts of our healthcare system, in our pharmacies, in our medical offices, and in our public health settings.
You bet.
Now I'll offer my amen. And I'm sure you both have some thoughts on this one, but I'm just, before we close, I want to know if there were anything else from the meeting that you think is worth noting here. I guess, Bob, I'll start with you.
Well, we had a lot of really interesting discussions around a new vaccine for the disease chikungunya, which is a mosquito-borne illness that can be a cause for severe illness in people, particularly in travel areas, but chikungunya can also happen in the United States. We talked about a new pneumococcal vaccine. We talked about a novel oral polio vaccine that may be helpful in outbreak settings. And we also talked about a different strategy for Haemophilus influenza type B vaccination in highest risk populations in Alaska natives and Native American population. Lots of information for discussions when we have a bit more time and more information on some of these newer products. Bill, do you have any other thoughts?
Well, I would just mention the kind of concerned and even distressed conversation about the recurrence of measles. Measles outbreaks not only in the United States, but in Europe. And that's our old nemesis, measles, which can be completely prevented by vaccination. And we're having outbreaks again because parents are withholding their children from measles immunization. And if anybody's listening to me who hasn't had their children vaccinated, please go this afternoon, take that child to the pediatrician or family doctor and have them vaccinated.
Thanks again for your valuable insights, Bob and Bill. And thank you all for tuning in to this inaugural episode of Contagious Chronicles with NFID. If you have a question for an NFID expert, please send it through the online form at nfid.org/contact. Your question may just show up in a future episode of Contagious Chronicles.